Good afternoon. During this event, you can post your questions in the Q&A at the bottom, and you will be recognized by the speakers. Please state your location when you ask your question. We will pose your question at the end of the speaker's presentation.
Good afternoon. On behalf of the National Association for Rights Protection and Advocacy, abbreviated as NARPA, I am pleased to welcome you to the fifth and final installment of our 2021 webinar series. My name is Kwame Blankson, and I am the president of NARPA's board of directors. My pronouns are he, him, his. I am a 47-year-old West African with dark brown skin and wearing dark rimmed glasses, a gray cap, and an orange V-neck sweater. Behind me is a white background with NARPA's black, white, and blue logo. NARPA's mission is to support people with psychiatric diagnoses to exercise their legal and human rights, with the goals of abolishing forced treatment and ensuring autonomy, dignity, and choice. These webinars are an integral part of furthering NARPA's goals. We are grateful, especially for our allies in this effort. Today's webinar is made possible through the efforts of Professor Anna Schubert of the University of Alabama, Sign One of Atlanta, Georgia, and the Georgia Advocacy Office. On behalf of NARPA's board of directors, I want to thank all of our partners, not only for the great work you do in your own communities, but also investing your time and resources to help NARPA reach a national audience. Thanks also to all of you who have attended some or all of these webinars. As always, I encourage you to take advantage of the online resources available on NARPA's website, on our Facebook page, and especially on our YouTube channel, where you and folks in your community can watch all of our webinars. During last week's webinar, I shared the sad news regarding the death of a beloved member of our board, Darby Penny. Through the efforts of her friends and colleagues, NARPA will host a memorial in Darby's honor via Zoom on Friday, November 19th. Please mark your calendar so you can participate in this special remembrance of a zealous advocate who added so much to NARPA, as well as to many of us on a personal level. Many of the people who knew her, they will be sharing their stories of what it was like to know and to love Darby Penny. More information will be posted on our website, and reminders will be sent to everyone on our email roster. And now, without further ado, today's presentation is entitled The Unacceptable Institutionalization of People with Psychiatric Disabilities in Nursing Homes. It is my pleasure to introduce our presenters, Nina Loewenstein and Robert Factor. Nina worked for nearly 20 years at Disability Rights New York, New York's protection and advocacy system for people with disabilities. Most recently as supervising attorney in the Program for Protection and Advocacy for Individuals with Mental Illness. She worked extensively on community integration litigation and advocacy for individuals with psychiatric disabilities in adult homes and nursing homes. Nina now works with the Disability Law Center, the Massachusetts PNA, on monitoring, investigations, and systemic advocacy in the Program for Protection and Advocacy for Individuals with Mental Illness, as well as the Program for Protection and Advocacy for Individual Rights. Nina is also a part-time legal analyst for the Long-Term Care Community Coalition, a nonprofit organization dedicated to improving quality of care and quality of life for people in nursing homes and assisted living. She's also a vice chair of the New York State Bar Association's Elder Law and Special Needs Sections Committee on Long-Term Care Facility Reform. Nina graduated from Wesleyan University and New York University School of Law. She holds a master's in public health from Boston University. Robert Factor is a professor of psychiatry emeritus at the University of Wisconsin School of Medicine and Public Health, where he was the director of psychiatric residency education for 10 years. For over 30 years, Bob has been involved as a clinician in community-based treatment programs for people with serious mental illness. He has been a consultant and expert witness with several lawsuits in state and federal courts that have advocated for rights and improved services for persons with mental illness. He currently has a private practice of general psychiatry and psychotherapy in Madison. Nina Loewenstein and Robert Factor, thank you for being here today.
Thank you. Thank you very much. Thank you for NARPA for welcoming this webinar. I just wanted to say for a moment how I came to develop this program. It really was spurred by the COVID devastation in nursing homes and adult care facilities. And New York was among the states that held hearings on COVID and congregate care. And there was much testimony on reforming the system and some testimony on reorienting it to community-based care. But my observation was that missing from this was enough attention to people with psychiatric disabilities who came into nursing homes in large numbers, and we'll discuss that, and continue to come in large numbers through broken systems of care and find it very difficult to leave. So I submitted testimony to the legislature on that topic, and in taking a look at this, I focused on New York then, but wanted to look at this nationally and present it to this audience. So thank you very much, and thank you, Bob, for joining me on this. Bob is just an incredibly empathetic psychiatrist with such a basis in community care, and he worked with us on litigation on this topic in New York State. So thanks for joining me. And I am a woman with short brown hair, a purple shirt and a scarf, and my background are autumn leaves and a blue sky. Thank you. Bob, did you want to say anything?
No, I'm just very happy to be here. I worked with Nina and other attorneys on the nursing home case in New York State, and much of this material, well, as Nina said, started with that case for me. And on that case, it was very clear to me how my approach, when I interviewed the residents in nursing homes in New York State, how my approach seemed very different from that of the clinicians in the nursing homes, in that I started with the idea that people are competent, and why can't this person live in the community with needed supports, rather than the idea that what would this person need, or why are they not capable of living outside the nursing home, and sort of from a position of what their strengths are rather than focusing on their deficits. And we'll get into that more as the presentation continues.
Yeah, the presumption seems essentially reversed in from the perspective of the nursing home. So I'll begin just by discussing this is an intersection of a long-standing failure to plan for an aging society with limited resources in the community-based mental health care systems. And there's a tendency to silo the supports. So the kind of bringing together of services has been part of the problem, and also the lack of adequate, affordable, and accessible housing. So I can start with the first slide, which just shows the second slide, it's our title. The second slide, please. So this is primarily a Medicaid problem. Medicaid is the primary payer for nursing home care, particularly long-term care. And the people that we're concerned about depend on public resources. So annually now we now have a quarter of individuals admitted to nursing homes have psychiatric disability, and also very importantly, they're most likely to be long stay residents. And they also, they tend to enter at younger ages with fewer physical disabilities and medical conditions, and also in comparison to their peers in the nursing homes. But this is also very much a problem of an increasing aging society. So there are a number of, fronts to confront. So let's go on to the next slide. This shows that nursing homes really expanded in the middle of the 20th century. It was a model that really grew out of trying to solve a housing problem in the beginning of the 20th century, where private homes supplanted almshouses when we first had federal funding under the Social Security Act. But it became fueled in the 1950s with Medicaid and Medicare. We already had federal funds developing essentially medical institutions. The Hill-Burton Act is a prime example, where there was building of hospitals and then nursing homes that shared standards of building standards. And this was really how we came to have this very much medical model. And with Medicaid and Medicare fueling that, there was this steady stream of government funding. And with that, the growth of for-profits that would take the government funding, and rather than turning it all into the care for the residents, there also was the profit. So there became this conflict with the providing of quality care. So by the mid-60s, 2/3 of nursing home residents are Medicaid, and then by 20 years later, we have over 75% being for-profit. And that has implications that we'll discuss. So Bob will talk a bit about the growth in these numbers of people with psychiatric disabilities stemming from the closing of psychiatric hospitals.
So as it shows here, in the beginning, really in the late 1950s through the 70s, there was a pretty drastic decrease in the number of people who were hospitalized in long-stay psychiatric hospitals. There are a number of issues that caused that, or were related to that. People often cite the development of psychoactive medications, but that's really only one, and not necessarily even the most important cause. One had to do with legal changes that changed involuntary treatment laws, and a general focus on civil rights that extended to people with psychiatric disabilities. There was a lot of research following World War II about treatment near home rather than in state hospitals that were typically far away from where a lot of people lived. They were built that way with the idea of out of mind, out of sight. But with the identification of something called shell shock in World War II, or actually shell shock was World War I, battle fatigue was World War II, and then it got forgotten after each of those wars, only to be rediscovered in Vietnam as PTSD. But there was a principle of treatment near home. Hospital care vastly increased because hospitals were basically run by the labor was done by many of the patients there, being paid $1 a day or not being paid at all, running the kitchens and the laundry and the grounds and so forth. And that became no longer possible. They had to be paid wages, minimum wage at least. And so the cost went way up. And the other issue was the vastly increased number of mental health professionals following World War II. So the hospital population went down, but unfortunately the community treatment systems didn't compensate, didn't develop commensurate with the increased people in the community. There were development of reasonable systems of care in the community, slow at first, Some of the earliest work was done where I live in Madison, Wisconsin, with the development of treatment near home, assertive community treatment, a titrated system of care. And we in Madison have written about that. But most of the country did not implement that kind of treatment. And so it's very difficult to treat people in the community if there isn't a system there. And so people were revolving in and out, the so-called revolving door syndrome, and housing became a major problem.
Go to the next slide. Thank you. So we have this tremendous growth in numbers, which also was added to by not only the hospitals closing, but people entered nursing homes from the community. I mean, these just became increasingly available. And as a person with psychiatric condition, maybe lives with a family and ages, and they can't, again, it's also an issue of not having the community-based healthcare. So the confluence of this precipitates this increase. And so we have some figures on how that increased. And so, but there's over 20 years between 60 and 80, there's over 100% increase in this population with psychiatric disability, which was inevitable without the community resources. Next slide, please. So the other side of large facilities with large numbers of people, and again, many being for profit, is that we have quality of care problems. So if we're looking at, by the 80s, these problems are pervasive, and the federal government steps in to take a look, and the Institute of Medicine directs study of all of this and finds pervasive problems with quality of care, with the training of staff and the numbers of staff, and the standards that have been emerging in states are not well enforced. And there, again, is a reluctance to close homes because there's no place for people to go. That, of course, can be an issue today. So focusing how this, and the IOM looked at how this affects people with psychiatric conditions. And again, the low numbers of staff and the lack of training in psychiatric rehabilitation, which has begun to emerge, as Bob has discussed. That's the problem in the homes. They don't have it. So there's an overuse of antipsychotic drugs, but also physical restraints to curb behaviors that are there because of frustration, depression, lack of activities, and all of this is highly inadequate, as the IOM found and other studies. And there was this study that's discussed below of these upstate New York homes where that includes this survey of the staff. And not only looking at, well, what's missing, but the staff themselves are surveyed and look in their view of most of the residents so that they have, quote, behavioral problems, and the staff restrain them and use psychotropic drugs. So we could look at the next slide, which concerns the effort to reform based on all of these findings. So the Nursing Home Reform Act, is this attempt to ensure quality of care and to tie compliance with that to those Medicaid, Medicare payments, to curb abuses, to curb physical and to limit physical and chemical restraints. So now, the drugs used need to be related to the medical condition and can't be for the convenience of staff, the lack of staff using them for convenience and not for punishment. There also, this is the standard, whether it's enforced, we'll look at, but then there's also the effort to limit the admissions, and to screen for the first time people who have psychiatric, also intellectual disabilities. So that these new screening and assessment requirements, both pre-admission and in resident review. So after someone's admitted, they're supposed to also be reviewed if there's a change in condition. So the first task is to be able to identify that, and there really are two screens. The first one is supposed to at least identify who possibly would be eligible for this, and to look, then the screen then is looking at the necessity of the nursing home care and to look at community alternatives. So by the 80s, we're starting to see that these would be available. And if someone needs to be in the nursing home, what are their specialized services for this disability that's been identified? So that's all under the Nursing Home Reform Act of 1987. And next we're going to talk about recovery and the ADA, and take a look at how, these important tools, how effective is it in the years that follow? So Bob, you want to?
Yeah, let me talk a little bit about recovery, and some of this may be well known to many of you, some it may not be. So the process of recovery involves really a transformation of thinking about a person in terms of that person's illness. So the illness is the major focus, and that's often the way physicians approach people with illnesses. It's not, it's fairly common to have someone be referred to by their diagnosis. Oh, have you seen the appendicitis in room 231? As opposed to a person with appendicitis. And I use and teach people, students and colleagues with whom I come in contact, I say, don't use diagnostic terms as adjectives. I don't use the term schizophrenic or asthmatic or arthritic, but rather a person with schizophrenia, arthritis, or asthma. But the process of thinking about recovery really became possible, especially in with mental illnesses, after Courtney Harding and her colleagues initially in Connecticut and in New England did long-term follow-up studies of people who were hospitalized in state hospitals for long periods of time. It turns out that after 20 or 25 years, about 2/3 of those people were about a third were not symptomatic. They may not have ended up in the place they thought they would end up prior to them becoming ill, but they were not symptomatic and not receiving treatment. And another third were very mildly symptomatic and minimally disabled, if at all. And a third were moderately or severely disabled. But the idea that most people can recover given the appropriate context and supports really came along in the 90s. And that's when the CMS and the Center for Medicare and Medicaid Services and the National Institute of Mental Health and the VA all and the New York State Office of Mental Health even started having recovery as part of their literature and with the internet on their websites. Whether they followed these principles in practice is another matter. So the idea is that we see a person, and if you go to the next slide, and the illness is only one part of their who they are, and they have all the rest of the things that all of us have, play, family, work, friends, and so forth. I see a comment in the chat that you shouldn't give labels to begin with, and see people as having needs, and I agree with that. Perhaps a label is a label can mean very different things to different people, and it can be a shorthand for what needs someone might have, but we can talk about that later too. So on the next slide, we can talk about the traditional medical approach, which really, if people get services, they are often swaddled with them. The other possibility is they don't get services at all. But the client and the person's case manager may be totally surrounded by services, as opposed to, on the next slide, seeing that the person is surrounded by various places where he or she can get support and have needs satisfied. And so in the areas of income, work, play, housing, education, and the various organizations and people who can provide supports in those areas as needed. And the whole idea, if you think about, and this is the difference between the approach that I believe I had when I went into the nursing homes and the approach that the staff had, is the staff saw people needing to be swaddled. They couldn't receive that in the community, and therefore they had to stay in the nursing home, rather than thinking about, as one would, if those of you who experienced this, at age 18, you went off to college, living probably for the first time in a much more independent setting. What kinds of supports and services and skills did you need in the area of housing and income, how to spend your time, how to manage an apartment, how to find an apartment and pay the rent and set up the utilities, manage transportation, recreation, socialization. Those are the things that people need. And if you present that to a group of students, they come up with that in 10 minutes. But the paradigm shift in the healthcare community took a long time to realize and to implement. And when you do this with students, the last thing they mention, if they mention it at all, is healthcare. But that goes there too. So this is an idea of recovery and how it can play in the process of getting people out of nursing homes. But in fact, the nursing homes weren't there when we visited them. So how can we make that happen? I'll go back to Nina.
Okay. So there's much that is really in common with the movement towards independent living, embraced by people with disabilities. So physical disability and conditions, these are also, something that's simply a part of the life of the individual and are managed and are not to be the basis for being isolated from others and segregated and not to be kept out of housing or to be kept from working. So these movements really are what propel the enactment of the Americans with Disabilities Act, which gives society, it's coming, in the course of the civil rights movement, to bring down barriers to include people with all kinds of disabilities in community living. And the importance of the ADA for this discussion, in part, is recognizing institutionalization as a form of discrimination. So we can go to the next slide. That's the community integration mandate, which becomes the basis for the later Supreme Court's decision in the Olmstead case, the Georgia case. And so this is an obligation on state and local governments to administer their programs and activities in this most integrated setting appropriate to the qualified individuals with disabilities, that is, those who qualify for those programs, to be able to interact with non-disabled persons to fullest extent possible. And this principle is I guess tested in its way in this Olmstead case, which was brought on behalf of two individuals, two women living in psychiatric hospitals in Georgia, where they're deemed to be able by their clinicians to be able to live in the community, but hospital, a state-operated hospital, doesn't move them out, there's nowhere for them to go. So the Supreme Court, an opinion penned by Justice Ginsburg, lays out this principle that the state's violating the ADA, where they're providing care for people with disabilities in institutional settings when they can be appropriately served in community settings. But there's this role for the treatment professional, and that will come up in the cases that we discussed. But she recognizes, the Supreme Court recognizes that this institutionalization is perpetuating the assumption that's unwarranted that people are incapable or unworthy of living in the community. We go to the next slide. The application of Olmstead is to all state and Medicaid funded institutions. So it's applied to nursing homes that receive the Medicaid funding and are also like looking at this as a state system of care. And also in this opinion is that the state has to have a plan for reducing the reliance on institutions, but they also are balancing it, their resources and what else they're, how else they are also serving people who have disabilities. But this is a big boost to the community integration. The Surgeon General report is mentioned here because that's also mainstreaming these principles of recovery that Bob talked about. So following the Olmstead decision, they're now under Medicaid is increasingly available the resources to serve people with psychiatric conditions, disabilities in the community. So we have increasing residential support, supported housing, supports to develop independent living skills. We have care management, case management to coordinate care. Peer supports begin to be recognized, community-based treatment. But despite these developments, there still are admissions continuing into the nursing homes, and it's hard to leave. So we are looking now at some figures following that. The Inspector General's reports and some university studies showing large numbers of people identified in those studies as having mental illness in nursing homes. And like the first slide we looked at, again, people with the label of schizophrenia tend to be admitted at younger ages and more likely to stay a long time. Notably, there's relative, half of the people that didn't receive the screening that they're supposed to get, which could have diverted them, or they're not getting the services that they need in the nursing home, which might help them to re-enter the community. And the nursing home services are, again, still highly inadequate. The staffing is still a problem, and the people, there's a later study that looks at this a few years later, but people with psychiatric conditions are actually more likely to go into nursing homes with less staffing and lower quality of care. Part of what we see nationally, which has not improved, is a continued overuse of the antipsychotic medications. And there was recent reporting on this, that identifying this as a problem in the 80s was supposed to lead to the reforms, but the standards haven't been enforced. And actually, 2011 found 1 in 7 nursing home residents, majority with dementia, with these powerful drugs, which are harmful and can cause death in residents with dementia. Bob, you might have some comments on what the kind of monitoring that's needed, and why this drugging is so overused in nursing homes.
Oh, well, and there was a comment by Sam Plover earlier that drugs can only be prescribed by doctors, so really the staff is only following orders. And however, it's true that the doctors or PAs or NPs are writing orders, but the order writers, the prescribers, often do so in response to the staff who are there 24/7, and the prescribers are not. And so the staff says so-and-so is really being a very difficult. And the prescriber writes an order for a medication, and the staff kind of expect that. What's missing here is what Nina referred to much earlier in our presentation, and that is the nursing homes are not very lively places to be. People are often bored, frustrated, angry. They want to be somewhere else, and they can't be. Their lives are not under their control, and people often get ornery and irritable in such circumstances. So the staff, at least in my observations, are often very immune and to observing that. I mean, that's where they live. It's like the smell in the nursing home. After you've been there for 5 minutes, you don't smell it anymore. But someone coming in from the outside smells it right away, at least for the first 5 or 10 minutes. So what can be done? Change the environment and use the medications either much less or perhaps not at all, but certainly not to quiet people down, which is the way they've often used. The risks, as Nina said, I mean, antipsychotics used with people with dementia can be risky. And so they're certainly overused, and what we know is happening, and there is in this slide, recent story in the New York Times in September, the monitoring of antipsychotic use in nursing homes, there was an exemption for people with schizophrenia. So the solution that the nursing homes came up with is identify more people with schizophrenia, or give them that diagnostic label, and therefore they're exempt from the monitoring.
Another comment about the prescription, there's often a fragmentation actually of the mental health services in nursing homes. I know in New York and Massachusetts, for example, they contract out much of the psychiatric care. And I've been in nursing homes where the administrators tell me, well, whatever this agency is that supplies the people, they're a psychiatric nurse or a physician's assistant, they then recommend to the physician who's on the nursing home staff what the drug would be, but they're not there's like a professional dissonance between these clinicians. They're not part of that integrated team. They're not on site all the time. Yeah, they're hearing from the staff that there's a problem, and the monitoring is really questionable. And on the last slide, there's just a note that these rates went up during COVID. There was a large study in Canada which showed how this happened. And again, you had low staff and a lot of frustrated people. So yes, so turning back to this is just it's an example of what goes on in the nursing homes. And in New York State, I wanted to just turn to this example of the large admissions from psychiatric hospitals into New York and New Jersey nursing homes that happened in the 90s, and the impact of that. And, studies showed that they had very high numbers of people who had, the conditions or labels of schizophrenia and bipolar disorder, and how long, again, they would stay. We can go to the next slide. These nursing homes a number of them were operated by a family that had ties to the governor at the time, Pataki, and it donated to his campaign. And actually, one of the operators sat on the Public Health Council in New York State. So these locked units that then said, oh, we'll take, as you're downsizing psychiatric hospitals, we'll take them. Well, they didn't have to impose any regulations on these locked units, and they became filled with people in psychiatric hospitals with, relatively limited needs for, the physical conditions were not the issue. It was where are they going to go? And these are locked units again because the staffing is low, and they're not going to have them wandering around the nursing home, rather keep them up on the unit. And this was investigated by Cliff Levy for the New York Times, and when I went back and looked at this article, it just jumped out at me that the commissioner of our Office of Mental Health called those units excellent long-term housing. So again, like, where else were these people going to go? They lacked the staff and the programming, and there were just hundreds of physically healthy people languishing there in their 30s and 40s and isolated, and often wearing these wander guards, which were bracelets that would trigger an alarm if they tried to move off the unit. So why these high admissions into these nursing homes? We have, the New York deal, but and in New Jersey, and these homes are, still today, I mean, they're really are the vestiges, and they're continuing to take people, maybe not from those hospitals, but overall, again, we had the lack of the affordable housing. It's not developing quickly enough, and people aren't a priority for that housing if they're in a nursing home. So they can't, there's limited numbers. So in New York State, for example, the priorities are given, and I believe still there's not a priority for people in nursing homes compared to people with from psychiatric hospitals, from prisons, corrections, and homeless, but not this particular kind of institution. There's the lack of the coordinated care, and the lack of sufficient care coordination, that now we have managed care, which makes it, in a sense, even worse, because there's caps on those systems. So we still have a very overloaded care coordination system. The PASSAR screening systems are ineffective, as was shown in that report. And so, for example, in New York State, you can have all these exceptions to get admitted to a nursing home if you're there for convalescent care, up to 120 days. And I walked into one nursing home. This was after our litigation had concluded, but there was a gentleman in his 40s, I later learned, walking around, who was referred to me by the ombudsman. And he had come into that nursing home having had a broken leg, and he had been in supportive housing, and he had the diagnosed condition of schizophrenia, but he'd been there 2.5 years. And so he'd never been reviewed again as required by this PASSAR system. And he, going back to that frustration, he was frustrated and became agitated at times. And then the nursing home took that as a lack of capacity, and they refused to discharge him. And so he was just caught. And we did advocate, and he was able to get back out into an apartment treatment program. But it's just an example of how people get in and get stuck. There are pressures to discharge quickly from hospitals. It's costly to be there. And nursing homes advertise. I mean, they're for profit often, and they'll say, hey, we've got this great program. And I've heard from so many families that had expectations for their loved ones, like, we thought he was going to get this great rehabilitative service, and I do not find that is the case. But often there's a lack of sufficient support and advocacy for people with psychiatric disability, and it's hard to return to the community after your housing is lost, because, as I said, the systems aren't there. You're not a priority. And Bob, I think you wanted to comment on some of these factors as well.
Well, as we've been a theme through this is the lack of community services, particularly housing. And in the New York State lawsuit in which I was directly involved, there were a very large number of people who I recommended could live in the community with appropriate supports. And part of the difficulty getting those people out was, even after the case was settled, the individual evaluators didn't believe that those people could live in the community. But another problem was that the numbers of services weren't sufficient to support all the people who were stuck in nursing homes, like the gentleman that Nina just described. So there's as we know, there's the problem of homelessness is not largely a problem of people with mental illness. It's largely a problem of lack of affordable housing and adequate housing. So we don't have those services, and we'll talk about what we can do to try to change this.
Yep.
Soon.
We certainly will. I mean, some of these things like the personal care supports, if we had an increase, the Biden administration, would want to greatly increase the home and community-based support system and be able to support a greater direct care staff. So if that's more robust, then states would be willing to expand that eligibility. If it's a resource that's not sufficiently available, the eligibility is going to be restricted. And this is exactly what happened in New York State, where what would come up, it's restricted to if you can't physically do the task. If you're someone who needs reminding to do a task, that's not enough, and that's not going to be funded. So that's definitely something to look at and to advocate for. The institutionalization on behavior motivation, that's studies certainly show, and settlements that have been underway in litigation, it's very hard to get people out, sometimes their own motivation. So how to address that is something that we'll talk about. There definitely are important strategies, but I think diversion is another thing to concentrate on. So we'll spend a few minutes talking about some of the litigation that's been brought, and I think that's a good place to look for solutions. Let's go to the next slide. Oh, yes. Well, I'll just mention before we get into the litigation that there starts to be these bundles of services, particularly, after 2000, the Medicaid waiver services to avoid institutionalization. And that's something to look at. It often isn't designed for people with psychiatric disability who are nursing home eligible. There is one in Colorado, which is, if others know of examples, I'd really like to know about them, but those kinds of bundles of services are really important for the community transition. The other program that's a Medicaid funded program is the Money Follows the Person. That's a federally funded, federal funds for state programs to support community transition. In the early years, those are small growing programs, and they tended not to focus on people with psychiatric disability, but that did improve a bit later. So we'll keep those in mind, and we'll turn to some of the slides about litigation. These Olmstead cases, there are several that focus particularly on the population we're concerned with. The first one is in California, the Laguna Honda Hospital, which is a nursing home that serves people with psychiatric disability. And so the solution here is very common to the later cases to put together that case management, to require the assessment and the discharge planning, and determine the most integrated setting, the preference of the person, and to improve that screening system statewide to consider goals and preferences and community alternatives. So the next slide, please. Here in New York, we have the Joseph S. case that we've been discussing. By the time we filed the complaint, the Office of Mental Health had stopped the large numbers of discharges from psychiatric centers. It did, again, require independent assessments and offer of community-based housing and services. One of the barriers or issues in this case was that there was not a monitor, which is an important I think that independent monitor is a really important component of successful settlements, because you have, there are all kinds of problems that arise in resolving these cases, and they require the coordination of systems, and there are all kinds of sort of pipeline problems with transition. There also can be these, in New York, there was continued role for the nursing home staff who, as Bob was discussing, they're risk averse, and the way that that Bob as a clinician would look at someone is the strength based. The nursing home social worker is not going to look that way, and there were many people where they weren't discharged despite a community-based assessment for transition to the community, and we didn't have the monitor to really work through those cases and sort of bring the state to to push back. And we started to, the monitoring was done by the nonprofit attorneys, but we really could have used the help. So those numbers were relatively low in the end that transitioned to the community. There also wasn't the inReach, which is the inReach going in and supporting the choice and continuing to go back to the individuals they change, are ambivalent, bringing them out to see places. There was no component of peer support or inReach, which so there were a number of people who said yes and then refused and then never left. Also, a number of people who had died before they were reached for an assessment or refused to be assessed. So some of the components I think are strengths in other settlements were unfortunately not part of the New York solution. But we could go to the next slide and just Illinois is an example of a case that did have the monitor, and that there was a requirement for cost neutrality there, which is a reminder of, under the ADA, bringing the Olmstead claims, is that the state does, they could bring defenses that it's too costly for them. So a number of these settlements require cost neutrality. But if we go to the next slide, I think there's yes, there's this cost neutral plan. It should be long-term, because over time those costs drop. And this was also found in studies of the Money Follows the Person program, that the state expenditures they might be high at first, in the first year when you have the most services in place, but then some of that drops away as people, they develop the skills and get used to doing what they need to do. And so that is very helpful knowledge. This was somewhere, there's a monitor's report that criticizes areas of lack of compliance, including leadership, pipeline problems, plummeting transitions, the lack of sufficient housing development. The leadership is really important above, if you can get there, because you might have more than one state agency coordinating. So there's be a Department of Health, for example, in New York, and the Office of Mental Health. And you need to work out problems such as that issue around those Medicaid waivers, for example, came up in New York State, where people can't go into the supportive housing system operated by mental health, which offers case management. They can't be on the waiver program, which could offer a good bundle of services, other supports, because those programs have care coordination. And so the agencies, unless there's leadership overhead saying you really have to be able to put this together, let's not have the care coordinator from the housing working with them, instead have the waiver person, or whichever makes sense, but there's no one above trying to resolve those problems. So that's just one example of an area where I certainly could have seen leadership being helpful. But so this is just they are transitioning about, looks like a bit better than 10%. Let's go on to the next slide. Briefly on Connecticut, that is a case, with smaller case, I think about 200 people involved in 2 nursing homes. One issue that came up in this case was there's a large number of people with so-called conservators or guardians who also had to agree on the plans. This issue came up in New York, and I believe in Illinois also. You know, guardians can stand in the way. So this issue connects to other issues. I mean, the preferences of the individual are not necessarily respected, and the guardian may be more adverse to risk and prefer the institutional setting. And so that can also inhibit transitions. Let's go to, I think this is the last of these examples. The Department of Justice has, there's a couple of these. The Department of Justice has a civil rights division that enforces the ADA and the integration mandate. And so there are 2 cases that are discussed here. The first, where they're involved, is in New Hampshire, where they end up joining a case brought by the protection and advocacy system. But their findings, I thought, were interesting here because they are describing people who have, you know, more complex conditions. So one of the pictures in the complaint in New York was going back to really the problem under the Governor Pataki, a large number of discharges of people who really don't have the physical conditions and needs to be in nursing homes. Here seems to be a look at an institutionalized population that's complex, but that still could be served in the community. So there's such a range of, you know, people who could be helped and moved to the community, but you need more intensive supports. So that had a consent decree, and there's a very recent monitors report, which again is recommending more in-reach into the nursing home, and also there was also I believe a psychiatric hospital that was the subject of this case. Access to waiver. Can you just go back to the last? I'm sorry. Access to waivers, providers, and here also the kind of housing that was developed was supported housing and also residential. So there's really a range of housing that could be available and appropriate that people would want to go to. So we can move to the last slide. So the Department of Justice investigated in Louisiana and found there one of the highest percentage in the states of adults with serious mental illness living in nursing homes, and found that they would want to leave the facility and routinely receive little assistance to do so. So their settlement concerned both people who are at risk for institutionalization, which is also an important area for Olmstead litigation, as well as those who are in nursing homes. So we can go to the next slide, and there's a very detailed settlement. So the state, I didn't put all the details in these slides, but a few that I thought were important. So the state has to develop a plan to divert, and they have to agree on timeframes for transitions. And you know, and then this next bullet goes back to what Bob was talking about, which is, you know, there has to be there's a presumption that the person can live in the community, and that has to be the basis from which all of these evaluations and the transition planning must begin. So that becomes a very different burden if it's followed through.
This presumption really means to ask the question, what would this person need in order for the person to be able to live in the community? With what's the minimum amount of support? And often that's not even, the question isn't asked that way. So that's what Nina's talking about.
Mm-hmm. So pass our improvements to that screening system and the person-centered, strength-based transition planning, support, and coordination. There's peer support and support as part of support for informed choice and the opportunities to visit community settings, which is really an important, particularly people who've been in an institution for a long time. They need to see what's out there. Bob, what did you find would you've worked with people who are transitioning from psychiatric hospitals. Is it similar to people leaving nursing homes and going to the community? What can we learn from those?
Well, I mean, the idea of either in hospitals or nursing homes. I mean, I was impressed by the number of people in the nursing homes who had no medical need for skilled nursing care, and that's a violation of the PASSAR process. And at least in Wisconsin, in my experience, it's taken much more seriously than it obviously was at the time in the mid-90s to the 2008 in New York State, where people were just certified as having skilled medical needs for skilled nursing care, which they didn't really have. But the idea either in the hospital or in a rehab setting is you start from day one. Well, we're going to get you out of here. What will you likely need in order to get out and be able to live independently with supports? Or by independently, I mean not in a hospital or nursing home 24/7 setting. And most people can do that. Not everybody can, but most people can. And you start with the idea that a person can, what will they need in the way of housing, monitoring, taking you shopping, taking you to the laundry, or whatever. But to start that from day one so that they don't get institutionalized and totally dependent on the institution for satisfying all their needs. And then you just have a bigger hill to climb with them. But people, when they see that it's a possibility, much more often than not, do it. So,
and is it possible to learn these skills in the nursing home?
Thank you for that. One of the, I think, underappreciated cognitive deficits of many, not all, but many people with schizophrenia is a greater difficulty than most of us have without schizophrenia in transferring learning from one context to another. So that if you think of going on a vacation in the country and you shop for a week's worth of groceries in a store in a supermarket that you've never shopped in before, the basic stuff is organized in a similar way, but you may run around for the last 10, 15 minutes looking for half a dozen items because they're not where you expected they would be. And it can be frustrating. And if a person with a serious mental illness experiences that, their level of frustration may trigger the onset of symptoms, and they do what they need to do to reduce the symptoms, which is to leave the store because that was the cause of the frustration. The underlying problem is that we all have difficulty transferring learning, and someone with schizophrenia may have a greater difficulty. So that, for example, someone learning to cook in an unfamiliar kitchen, if you've moved from one apartment or one home to another and the kitchen isn't laid out the same way, it takes some time to get used to the new layout. The person with schizophrenia may have more difficulty or may not be able to do it. The solution is to teach them how to cook where they live. So in vivo adjustment and education, not in vitro, in a test tube, which would be in an OT kitchen, in a nursing home or hospital. That doesn't work because they're going to have to make yet another transition. So that's an argument for doing it in the community and taking people out this is where you're going to live in 2 weeks. Let's get you used to this place. So we'll go out there for 3-4 hours today and get you settled, and you can practice, and then you go back and you do that a few times before the actual move. Obviously, that's more labor intensive, but it's worth it. And as Nina said, the startup cost may be much greater than the maintenance costs.
Yeah, well, another barrier, I hate to bring up all the barriers, but often there's like there's these transitions to the community-based Medicaid, which prevents services coming into place before you leave the nursing home. So there's another problem that we advocates have to work on. Let's go to the next slide and just see if there's anything useful here from the Louisiana settlement. I think it's really talking about everything we've been talking about. But you know what one thing that's important in the settlement, again, is this requirement to expand services in the community. I mean, there's just a general strengthening that goes on. So there's this notion of paying attention to that risk of institutionalization. And that's really the systems reform, has to be part of the systems reform. So let's go on to the next slide. We've been mentioning a number of these as we've gone through, so I won't repeat those discussions. I think we've really talked about everything, the importance of the presumption to live in the community, among them. I think that perception of risk is so different from inside the facilities versus, the strength-based. Bob, I'm interested in when you met with residents or meet with people you work with, what is the strength-based? How does that play out? Why is that so foundational to?
Oh, well, one of the things that I asked, the first question I asked after, we introduce ourselves is, well, how do you spend your time? What do you like to do? And people in the nursing home, sometimes they could answer that very, very directly. This is what I'd like to do, but it's not here. Sometimes they drew a blank, and in many cases, that's what was because that's what they got used to because they had been there so long, and it was painful perhaps to even imagine engaging in things they would like to do because they would only be disappointed. Mm-hmm. So I start out with, well, what do you like to do? What can you do? What are your strengths? As Nina said a few minutes ago, these places are very risk averse, so they don't want to send somebody out because, God forbid something within a short period of time or even a longer period of time, something bad would happen to the person and they would be blamed. And all of life involves risks. We all know this. If you live in a bubble and never go outside, even that has risk. But you're lowering your risk, but you're not living a life either. So it's a different, a different place to start. And being too risk averse is in fact risky itself. So taking mindful, calculated risks is part of what we all do every day, driving from one place to another. Bad things happen in cars, but the benefit of getting from here to there outweighs the small but non-zero risk. And so one has to calculate the benefits of leaving the nursing home or the long stay hospital.
And the risks of being in the nursing home is, I think, we are really learning. So that's to be considered also. So the last slide is just a couple of things going on now, and then we'd love to get to questions. So there's this FMAP bump under ARPA. I don't know what's going on in every state, but a couple of states I know about are using a little bit of it towards the issues that we're concerned with. New York's going to have peer supports for older adults with psychiatric conditions, and Massachusetts will improve its PASSAR program. I don't think this is a very common focus, but there is potential here if states are continuing to develop their plans, and CMS is now approving those federal funds for HCBS. And of course, the money follows the person programs in each state. That is an accessible program. How much they also focus and coordinate services, very variable. And the last final slide are a few other questions to look at in your area. You know, how well integrated are services? How adapted? Is there accessible supportive housing? How is what's the eligibility for personal care services? I also have some links for, in New York State, the Geriatric Mental Health Alliance has developed recommendations that there may be a program like that in your state where, you know, I thought they took a great look at this growth in the problem and recommendations for our state to improve it. So I think with that, I'd like to hear at least a few questions, and I'm offering, if we can't get to everything, I'm happy to try to respond through Anna. So what's the first?
All right, we pulled off 5 questions here. There are some that are quite lengthy, and those will probably have to be answered afterwards. But here's the first question from an attorney. Can Nina address what can be done when guardians, conservatives thwart community placement, especially when these are public guardians and not family members?
Yeah, they're often, it depends on the circumstance, but there could be you may or not be able to remove the guardian for ignoring the preferences. We did actually, in the New York case, Joseph S., one of our named plaintiffs, had a community guardian, and we actually brought the agents, we brought a couple of people from the agencies to see the housing where he would live, and they sort of turned around. They did agree to his transition. So there can be some persuasion brought to bear, but the guardian ignoring preferences is, you know, they're not, usually under the law, they're supposed to consider those preferences, but there can be risks to going back and trying to get the guardian removed. I think the question is, would there be anyone better? I mean, we have such, in New York, I mean, the choices really are not so available, but you know, that was actually something that happened with the named plaintiff, was that we managed to persuade them by actually showing them how coordinated the supports and services would be and the kind of housing he'd be in, which was it was a supported apartment in a residence that had staff.
All right, another question. How do you monitor the health of the policy impacts as being held and analyzed through algorithms versus actual field work to assess the ecologies of and within the operational field of the nursing homes?
I'm not completely sure I understand the question, but if it's like looking at sort of the you know, kind of what are these numbers versus what's happening in the home, I mean, I think you need both to see what's going on the ground. But did you have a thought on that, Bob?
No, I mean, I'm not sure what the questioner is meaning by the algorithms, but I'm
just maybe we can have
Okay, we have another question. How can we convince state and local politicians to invest more in HCBSs?
Yeah, that is like, and the worker shortages. I mean, there's just, this has been, it takes a coalition of advocates coming, you know, together. I think, you know, if only the Biden plan could pass, and there'd be the federal push, you know, to support state programs. Of course, you know, there's a question there, but how do we persuade them? Part of it is the cost. Maybe there's cost arguments to be made that, you know, using those. And there's a couple of slides of references, and there's a good study on the money follows the person, and that the costs over time to live in the community are less than in the institution. So I think dollars is, it's not, we all believe in the dignity and choice, but legislators may be looking at bottom lines, and that may be a really good approach, is using that kind of data.
All right, another question. What are the most promising existing community-based mental health programs or models of programs you specifically like to see more of?
I'd like to see basically more resources put towards community treatment, assertive community treatment teams, which have been empirically proven to be, or demonstrated to be, quite effective. But there are ways of broadening them. I know many people in the advocacy movement see them as very intrusive, but they don't necessarily have to be. And because I think, if you get the, if this is part of a whole other spiel, which I'm not going to get into, but at length, but if a lot of prescribers, for example, say that my goal for my client, my patient, is to get them to take medications. If you ask the client, what's your goal? My goal is to, I'd like to be able to get a little job so I could earn a little extra money. I don't want to earn too much to lose my benefits, but just a little extra. Or I'd like to be able to have a better place to live, or whatever. The good programs find the overlap, like the Venn diagram. So I can, if I think medications are really good or help someone, my goal is then to sell that to this other person. And I've done that, for example, with one person I worked with for some time, and I've written about this, where he was a good chess player. And when he was more psychotic, he couldn't play chess. And like any good chess player, he preferred to win rather than to lose or draw. So I convinced him, and this took quite a while, let's do an experiment. You take meds for 6 weeks and not take meds for 6 weeks. And we actually worked with a pharmacist who made up, it was double blind. Only the pharmacist knew which 6 weeks he was on meds, although I think he probably knew. And then he kept track of how many games he won and lost. And he played at the Memorial Union at UW, and you could always get a good game with the chess clock, the real thing, just out of Queen's Gambit. Turns out he won more games when he was on meds. And so that convinced him. It wasn't that, gee, I'll put up with these side effects, but winning is better than the side effects. So it's the idea of convincing people in terms of what they want. So assertive treatment programs can do that. That's one thing I'd like to see more. Assertive programs for people with not just psychotic illnesses, but post-traumatic stress disorder, or difficult personality disorders where they get into trouble, and clubhouse programs like Fountain House in New York City, Fountain House model programs, where there's a big focus on work and engagement, more money, more programs that involve peer support, which is incredibly valuable, both for the people being supported as well as the peers doing the support. So there are a lot of places where such good programs exist. It's also important for them to be coordinated into a system of care, and that's a whole other topic. But I guess, but back to the issue of this algorithms, you measure what you measure. So, how do you monitor the health of policy without going to algorithms? Well, going out and assessing programs is time intensive, and anybody who's been through accreditation site visits knows that, what site visitors see in a few days is not necessarily the whole program, but I don't have a good answer to that, other than it's sort of, you know, you kind of know it when you see it. But the bottom line is that walking into these nursing homes, there are a few things that could be worse. So almost anything in the community, I think, would have been better. That almost anything that provided people with support so they didn't fall flat on their face.
I'm noticing in the chat there's an interest in sharing the questions. So if there's any way to do that, happy to try to answer more later. But we
All
have
right.
time for another couple of questions. I saw a question on affordable housing, if that would be helpful to discuss.
Okay, we have about 5-6 minutes left. I have one question here. Can you provide any insight on strategies to overcome the issue of not enough affordable housing where people can transition to? And I want everybody that the questions that are left, we will try to get to them over the next couple of days.
Okay. So the affordable housing, you know, that's of course a huge issue. If there's there can be ways to leverage, if there some capital fund, well, there are a couple of things that could be done. One is to deal with the housing that one has and make it accessible. And there could be, you know, and in New York, we were starting to work on the Office of Mental Health being able to fund modifications to homes so that that are in that were in the Office of Mental Health system, modifications for homes so that they are more accessible, and to survey the issue of lack of accessibility. So there is probably more that could be done with housing stock that's in both supportive and supported housing, or the most independent housing. So I'd say beef up accessibility, and there could be state resources for that, which would be, you know, that definitely would be cost effective. There also may be funds available for capital funding available in leveraging HUD funds, which would be directed for people who are homeless. But if people are in nursing homes, they've lost their housing. And I think, I mean, New York State kind of missed the ball on that, where they have had 5 years of capitalizing funding in a supportive housing system, but they'd only serve people coming out of nursing homes if they had lost the housing before. But I think they'd enter the nursing home, and that's certainly an issue of people who are homeless going to nursing homes. But I think, you know, I think another round of that could solve that problem. I don't think there will be. I just, you know, affordable housing is a huge issue, and I would love to hear more ideas on that. Do we have time for another question, or?
I would just make there's one comment about AOT, which is sort of a community coercive treatment. Assertive community treatment doesn't have to be coercive either with the court, involving a court order or other ways. It doesn't have to be that coercive. Is there some, you know, on the spectrum of persuasion versus coercion? Well, yes. I mean, a stop sign is coercive, but we hopefully follow it. And obviously, it's come up in the general talk about you know, mandates for masking or vaccination. Are they like stop signs, or are they way more coercive than we can tolerate? And obviously different people have different views on that. But I've worked in assertive community treatment teams where nearly everybody is not on an involuntary order, and they participate in it because we've sold them that it helps their quality of life. And I think it's possible to do that. It takes time and skill, but it's certainly possible. Another question?
All right, I have one final question. What about solutions? For example, medical legal partnerships that place a free attorney in an institution who can act to help ensure quality of care and, most importantly, transition into the community.
Yeah.
Places do that. Why not?
Well, right, it's like the sometimes hospital systems or the psychiatric hospital systems will have state-funded sort of public defender team that are there, and the nursing homes don't have that. Absolutely. I think, yes, let's have a P&A for nursing home residents. And many of these issues, by the way, are common to, adult homes, adult care homes, boarding houses, rest homes. There's a lot of the same issues of institutional versus communities. So.
Okay, and I think one little final question, I hope it can be a short one. How about some strategies about the problem of health departments dumping clients into nursing homes?
Just dumping them there. Yeah, well, it's again, it's how people are coming, and that these are the acceptable, available. Yeah, it's that's a big issue of people being dumped in, like from hospitals, and that they're not, there needs to be diversion. And I'm sorry, sometimes I think that litigation is the only way to get some,
That may be, one of the reasons why I think it happens is that it's an easy thing to do. And if it were made more difficult, and PASAR, I assume, was one attempt to make it more difficult so that people with skilled nursing needs went there, but others didn't.
PASAR's only for people who are identified as having serious mental and intellectual
Right.
disease. He's really not, you need, there's some screening for everybody, but not to that extent. But yeah, like there's
make it more difficult to go into the nursing home and make it easier to go into the community, which would be providing more services, which requires more funding and people to develop them.
Well, when we come live, let's all have a round table and we can discuss all these really great questions and concerns. Thank you so much.
Yeah.
Well, Nina and Bob, do you have any final comments before we go to Kwamina?
Nope. Thank you.
All right.
Thank you guys so much for all of that. Nina, Robert, we really appreciate how you've educated us, giving us not just valuable information, but also sharing your personal experiences. On behalf of NARPA's Board of Directors, thank you. The PowerPoint for this webinar is going to be available on NARPA's website, along with all the others from the past webinars. Thanks also to the people behind the scenes who made this webinar possible. That includes the tech experts helping to host the Zoom feed, as well as the members of NARPA's conference committee who helped see this undertaking from its inception all the way to this successful conclusion. The success of our webinar series has really hinged on the high quality of proposals we received, and the 5 presentations that we finally chose were selected because they represent what we thought was a deep dive into timely and widespread problems that deserve more attention. I would encourage you to start thinking ahead now so that you can submit your own unique idea when NARPA sends out the next request for proposals. As you know, normally this kind of presentation and Q&A session would be part of our annual conferences, something that we for years took for granted until the pandemic disrupted our normal way of doing things. But now, not having a conference last year has really taught us to count our blessings. So as I've said before, we really miss being able to meet face-to-face and have opportunities to connect with our allies and co-conspirators. So please do stay tuned for updates regarding our next in-person conference. All the announcements will be made on NARPA's website, on our Facebook page, and via email to anyone who has given us their email address during the registration process for these webinars. We look forward to seeing old friends and meeting new ones there. Finally, here's one last reminder that NARPA will host a memorial in honor of Darby Penny via Zoom on Friday, November 19th. During that, many of the people who knew her best will be sharing their stories. So please mark your calendar to participate in what we think will be a special remembrance of a tireless advocate whose absence will definitely be felt. Darby's death is a great loss to all of us, but our memories of her can help us soldier on as we continue to do the kind of good work and zealous advocacy for which she was known. And with that, thank you for being a part of this webinar. Please stay connected with NARPA and access all the resources that we make available online. Goodbye, and I really do look forward to seeing you live and in person at our next conference. Thanks.